Yes. Am I audible? Am I
Yes,
audible?
sir. Absolutely.
Yeah,
Absolutely.
excellent.
Go ahead.
Thank you. So in my next half an hour, maybe I'll take 25 minutes to talk and then allow time for questions if there are any. Thank you, Rishvital sir, for those kind words of introduction. It's always a pleasure to be at ESI and to be physically present at the meetings. Had always been a pleasure. I've been there from my trainee days until the physical meetings over. Now it's a great pleasure to be here for the first time in virtual. I bring also the greetings. I was at the inauguration ceremony also, and I brought greetings from the Safis. ESI was very much a founder and very much a conceptualization force behind the South Asian Federation of Endocrine Society, as ESI members are the majority force behind it and perhaps the inspiration behind Safis. And as I said that day, it's always a pleasure to be at ESI. I wish I was there physically, but then we'll perhaps meet maybe next year physically. I was also speaking at the Bangladesh Endocrine Society meeting, which was happening yesterday and today. And it's always a pleasure as South Asian Federation to share knowledge and to meet across. So my topic is a tough one to cover as well as to give an overview. So what I'm going to do is to do that. I have divided my talk into two parts. In my first part, I'm just going to define and show you an outline of what secondary osteoporosis is, and just give a brief outline on how to investigate and how to proceed. There are numerous causes, and we'll just quickly tabulate them. And I'm going to go through each one of them. In my second part, I'll go through more interesting parts, where we'll talk about specific issues that relate to treatment as well as particular data. So we'll talk about how treatment data pertains to treatment of underlying conditions alone would reverse the secondary causes and reversal of the bone loss. We'll also talk about lack of data or availability of data with regard to specific treatment in these conditions that would be of interest. As I said, the conditions are numerous, but I've just picked them as that of the majority interest to me and also are controversial. So I've just anorexia nervosa, thalassemia, cancer treatment-induced bone loss, pregnancy and lactation-induced osteoporosis, glucocorticoid-induced osteoporosis, and a few words on diabetes and osteoporosis, just to do justice to the topic. So Sri Lankan data as well as South Asian and internationally, we know that osteoporosis is common. So Sri Lanka, you can see from multiple studies, it's as common as 45% in 65 plus age individuals and can be a major problem. And if you look at world data, it is common. It is as big. Fractures are as big as the top three, as they say, breast cancer, MI, all that put together. You have osteoporosis as a common problem. And if you look at the data, the rise from 2010 to 2040, you can see that compared to the rest of the world, Asia is projected to have the highest rise in the world over the 30 years from 2010. So osteoporosis is a common problem worldwide. So to talk about secondary osteoporosis, I'm just going to deal with a case just to show you an example of how we would deal with secondary osteoporosis. So here is a woman, 73 years of age, whose X-ray is very clear. She's presenting to us with backache, and the cause for backache is very clear when you look at her. She's got a bent over back, and the cause is clear as we look at her X-rays. She's got multiple vertebral fractures. Her DEXA scan is discrepantly lower than in the hip on the spine. That's because of these compressions. So don't get fooled by a T-score in the spine being somewhat relatively better looking than in the hip. That is because of all the compression. She's got severe back pain, and she's got osteoporosis with fractures. Now the question is, does she have osteoporosis? Of course, by WHO definition, in a postmenopausal woman, a T-score more than minus 2.5 defines her as having osteoporosis. She's got fractures, so you don't even need a DEXA scan to diagnose osteoporosis. And if we take a history and establish that it was minimal trauma-induced fractures, then it's good enough. Now, the vital question that we ask in each one of these patients, why did she have osteoporosis? Why did she break her bones? Are the crucial questions. In that way, we always try to exclude in every patient, does this patient have secondary osteoporosis? In my next slide, I'll ask the question, how common is this problem? But in this patient, we are going to ask this question in this 73-year-old woman who might have age-related or so-called idiopathic osteoporosis. Do we have to look for secondary osteoporosis? So world wisdom says, yes, we should do some basic tests, ask some questions, family history, etc., evaluate. So here is our basic test. What stands out at us is that she's got high normal calcium, not hypercalcemia, high normal calcium. ESI is more than 100, and she's got marginal vitamin D deficiency. So vitamin D deficiency is found in about 60% of the population, so you would find it in most of these individuals whom we investigate. ESR stands out at us, and when we do further investigation with serum protein electrophoresis, you see a monoclonal gammopathy here. And so the diagnosis here is that she's got multiple myeloma. She requires not just bisphosphonates, but she requires specific therapy for multiple myeloma. And it's important not to miss it, particularly because of the severity of the condition, but also because of the onset of the condition, as well as the rest of the biochemistry points us, the hematology, etc., points us towards a secondary cause. So what is secondary osteoporosis? So it's defined as osteoporosis, in other words, low bone mass with microarchitectural alterations that leads to fragility fractures in the presence of an underlying condition, that is a disease or medication. So it's, in other words, osteoporosis in the presence of a disease or medication that results in that. How common is it? Some data suggests, as has been referred to at the bottom here, that it can be pretty common. So in men, particularly in younger men, in most of the younger men, you would find a cause, and we would look for a cause. So 30 to 60% of men overall, but in most of the younger men, we would look for a cause. Even in postmenopausal women, like this woman who presented to us at 73 with fractures, we can still find a cause. And in about 30% of postmenopausal women, you might find a cause. In younger women, the premenopausal so-called women, you might find the disease a secondary cause in more than 50% of the patients. So it's pretty common, particularly in men and younger women, but not uncommon in postmenopausal women as well. So now the question is, in younger persons, the Puritans among us wouldn't call it osteoporosis in younger people. We'll just call it bone loss or low bone mass, but we are not sure whether it was a loss of bone or just low bone density, because we don't have proof that they ever had higher density in the past. So how do you diagnose in the young? According to the International Society for Clinical Densitometry, in lower than 40 years of age, The z-score less than -2 standard deviation is defined as low bone mass or osteoporosis of the young, and then you would have to look for cause in them. IOF, though, says yes, it's okay, but only in the under 20 we will use a z-score. In more than them, we would use a t-score. Most people would think that is not the right way to do that, but that's how International Osteoporosis Foundation defines it as. So in general, most people would use both of them based on if the person has gone through peak bone mass, that is, if they have attained at least 30 to 40 years of age, you could start using t-score. Otherwise, you would compare them with the z-score. So in this graph, you can see what T and Z scores mean. T score means you are comparing with the ideal bone mass for that particular race and that ethnicity and that gender. The Z score is for that age specific mean is what you compare that with. So the Z score is for that particular age and T score is for that race and for that gender. How bad it is compared to that person's. So in my next few slides, I just want you to glance through, I'm not going to go through details, but I just want you to glance through the numerous types of causes that we see causing osteoporosis or bone loss in younger people and older people alike. So you can see that a whole lot of hormone excesses can do. Growth hormone excess, cortisol excess, hyperprolactinemia due to the hypogonadism it causes, hyperthyroidism, hyperparathyroidism, etc., and hyperaldosteronism do cause a few deficiencies like growth hormone deficiency, hypothyroidism due to low bone turnover. Also, hypogonadism is a major cause in most of and perhaps the commoner cause in women, and pregnancy-associated osteoporosis, which I will speak about. So there are quite a lot of endocrine causes, both excesses and deficiencies of hormones. There are quite a lot of nutritional causes, eating disorders, excessive alcohol, malabsorption of calcium and vitamin D or inability to take them, malnutrition, etc. can lead to that. Rheumatologically, rheumatoid arthritis, ankispond, SLE, and certain connective tissue disorders, certain renal diseases. There are drug-induced, perhaps are world's #1 cause of secondary osteoporosis, and steroids lead that list. Steroids. But there are many other therapies like HIV therapy, hormone deprivation, which I will talk about in a while in relation to cancer therapy. Also, men undergo anti-androgen therapies for prostate cancer and etc. PPIs, diuretics, both thiazides and loop diuretics. Anti-epileptics cause vitamin D problems. Then anticoagulants, etc., are common causes. Then we have a whole lot of hematological causes, multiple myeloma and its variants. Then we will have a few words about thal major, which in younger and older people for various reasons can give you a low bone density, partly because of the replacement of the bone marrow with the bone marrow enlargement, as well as hypogonadism that it causes. GI malabsorption, which I spoke about under various things, chronic liver disease, and primary biliary disease. So here is a complex topic summarized in one slide, but I'll try to make it pretty simple. So here is an osteoporosis patient presenting to us, and how do we go about and exclude a secondary cause, like I showed you in my second slide. So here is a patient with osteoporosis who presents, and we would take a history, look at risk factors, do physical examination, look for clues for secondary as well as drug-related issues, take a careful drug-related history, do first level laboratory tests which are listed here, and I showed you some examples of that. So if there are no abnormalities detected, you would normally treat them along with correction of vitamin D, calcium correction in their diet, as well as supplementary calcium if needed, and treat them with appropriate therapy with anti-resorptives or the usual therapies, and monitor them. If they don't improve or their bone density declines, you might want to reevaluate them for a cause. And that's what I do in my practice, and that's what most people would recommend. That you initially do a evaluation, you might miss a few causes, and they will also become apparent if you haven't got a patient who is responding to you. Now, if at the beginning the patient has got any derangement or there is clinical history is not so very clear, then you can go ahead and do further testing and also do bone biopsies if it's not clear. There are sometimes cases that are very clear, for example, pediatric cases where there are hereditary causes like osteogenesis imperfecta, etc., where you would like to do genetic testing and a bone biopsy, etc., to look for other causes. So where a referral is required for a specialized bone disease will have to be considered. But in most of the cases, general testing would exclude underlying causes, and a good history and drug history and investigations will exclude secondary osteoporosis or help you find some causes. So I'm going to now go to my part 2 of my slides, where I'm going to talk about therapy issues. So in my first part of the therapy issues, I'm going to show you data where treatment of the underlying condition improves the bone. So we say that an endocrinologist will usually correct the underlying condition and watch the bone, whereas a rheumatologist would usually treat with bisphosphonates. So myself being an endocrinologist would usually first naturally show you conditions that would obviously improve with treatment of underlying condition. So here is new data from September this year, where in this German series from Munich have looked at a large series for 7 to 8 years, where they've looked at these patients carefully with bone turnover markers and bone density for 2 years. Data is what is shown here to see whether resolution of the disease, that is remission of Cushing's, would result in sorting out of the bone condition. What you can see here are the 4 bone turnover markers, and you can see that the bone turnover, even after in fact, this baseline and 1 year, 2 year, actually after remission, the bone turnover actually goes up. So it's probably the reactivation and the remodeling of the bone happening when the cortisol excess is taken out, because here you can see the T-score improving after the remission. It's not treatment, but after treatment. Then the patient remaining in remission, the patient improves in bone density. So unless there is a fracture, I don't personally treat a Cushing's patient. I simply tell my juniors that we would watch the bone density, but correct their vitamin D and calcium if required. So here is another example of another data set from 2016 after cure of hyperparathyroidism. So here you can see bone densities in various regions where the bone density goes up. And in particular, in men, it improves faster than in the others, but it goes up in general after cure of hyperparathyroidism. So without treatment with bisphosphonates or other antiresorptives, you could result, once you take off and cure the disease, you could correct it. Here is a data set from 2019 that looks at what happens if you treat early versus late interventions with anti-TNF treatment in Crohn's disease. So even in inflammatory bowel disease, if you treat the disease specifically early enough versus late introduction of the treatment, you can see that the bone condition is better, bone loss is better and less if you have treated the patient early enough with specific. So the osteoporosis percentage was lower in the patients. Celiac patients, if gluten-free diet was given, you can see here P-scores being significant, that the bone density was, and the quantitative CT here showing that the patient's bones were better with gluten-free diet. Just that alone, and the nutrition being sorted out would sort out the bone. Anorexia is a different kettle of fish, as you can see here. There is this meta-analysis published 3 years ago, which had looked at 19 studies, because we have had different sets of results, is why a meta-analysis is required. More than 1,000 participants. So if you just cause weight gain, would the bone improve in anorexia nervosa? If you had, the data set was that if you just caused weight gain, the patients wouldn't get better. If you had given bisphosphonates, younger women didn't respond, but older women responded. So that's the result of the meta-analysis. So in anorexia nervosa, just resolving their bone, the anorexia wasn't good enough, but giving bisphosphonate wasn't good enough either. But estrogen in the younger women was useful, and transdermal was what they had used. And in older women, they had used bisphosphonates. Teriparatide, which I'm showing in the next slide, was effective in anorexia nervosa rather than bisphosphonates in the younger people. In cystic fibrosis, as you can see, I've transited from data for underlying condition treatment to specific treatment in certain conditions. So cystic fibrosis, you can see the Cochrane review here. Bisphosphonates are effective. Did not result in fracture reduction, but it did result in BMD improvement, as you can see very clearly in all of the studies that have been done. In Thalmajor, we have a problem. These are usually younger people who are referred to us with hypogonadism and low BMD, and we usually wonder whether to treat them or to ask the pediatricians and the hematologists to look after their bone density, their chelation better, and to get them better. Of course, we need to give them hormone support, hypogonadism treatment. But here you can see that in the adolescents and the older adults, a bisphosphonate treatment in this meta-analysis does work. It's a bit of a busy slide, but does give you better BMD if bisphosphonates were used. Denosumab also, compared to placebo, works for Thalmajor. So there is that option. I showed you inflammatory bowel disease and how specific treatment with anti-TNF works. And here there is data to show that bisphosphonates do work as well, favoring the bisphosphonates here across the studies, where bisphosphonates also do work. In my next few sets of slides, I just wanted to show you 4 sets of conditions that are of interest: treatment-induced bone loss. So the carcinoma breast in premenopausal women is treated very specifically. Most of the premenopausal women are HER2 positive, and they are usually given adjuvant chemotherapy, tamoxifen usually. In the older women, aromatase inhibitor is given, which is definitely a bone loss causing treatment. But tamoxifen and ovarian function suppression also causes bone loss. I'll show you in my next slide. Adjuvant chemotherapy is then can be tried and is usually combined with trastuzumab along with the adjuvant endocrine therapy. If the patient is HER2 negative, which is in about 1/3 of the patient, just adjuvant chemotherapy is given. What you can see here is that as a result of the therapy, a rapid bone loss occurs in these patients. So how do you assess these patients? Can you use FRAX? Because FRAX at the beginning underestimates what's going to happen in future and usually misses the risk. If you just use the Z-score at the beginning of therapy, you have missed it, and that alone, or T-score in the older at the beginning itself is not good enough. Can you use bone turnover markers? Whatever you're going to use, you can see that this loss is pretty rapid. Within the first year, there is rapid bone loss. So none of these are pretty effective for prevention of this rapid weight loss that is seen. So what the studies have done is to look at the use of zoledronate. As you can see here, at the end of 3 years and at 5 years in CTI-BL, you can see no zoledronate. There is 12% bone loss, massive bone loss compared to zoledronate. And at the end of 5 years, there is even a positive change. And this CAL-GB trial, which had looked at 4 milligrams of zoledronate every 3 months for 2 years, had shown that in this 439 patient cohort that is a good way to go. We can prevent this rapid bone loss in these patients. So it's almost standard now that when these patients are put on this therapy for adjuvant endocrine therapy altering their ovarian function, that we would go ahead and recommend zoledronate even before bone loss occurs. The other benefit seems to be that if you give zoledronate, there is a slight survival benefit that the once given zoledronate seems to do better in terms of cancer-free survival. It's not shown in all the studies, but in this study, for example, ABSCG 12 trial, zoledronate did improve cancer-free survival in patients. In the interest of time, I'm going to just move on to my next topic, which is pregnancy and lactation-associated osteoporosis. This set of X-rays was in the recent article that appeared, and you can see that all of these young women are presenting in their lactation period with severe bone loss and fractures. So they have multiple vertebral fractures, all of them. It's unfortunate because these are young women and they have a child to care for, and they get this. About 200 odd patients have been reported in the literature, but I'm sure there are much more than that because even my own patients haven't been published in the data. Normal treatment is that we would look for a secondary cause for these patients and would give a bisphosphonate. Zoledronate works well. As you can see in this series, all the patients did respond to zoledronate therapy. The only problem with giving zoledronate for young women who are of fertile age is the worry that if she conceives again, usually they would want to have a second and a third child, is that if she conceives again, the teratogenic risk of it. So that is something that we need to think about. Normally people would say, give bisphosphonates for a short time, give a drug off window for a year or two, then allow them to become pregnant. So there are such a recommendation. There are some studies that have actually looked at exposed fetuses and the embryological outcomes of the newborn baby to show that there have been no significant negative outcomes in zoledronate exposure. Nevertheless, there is a caution in giving zoledronate to fertile age women. So the other option, if the patient can afford, because this is a short-term therapy that is required, is to use teriparatide, which works fantastically well for these patients, as you can see, compared to control. The ones who were given teriparatide did improve their bone density. And just to remind you, teriparatide is used normally up to 18 months, maximum 24 months. Now I'll move on to glucocorticoid-induced osteoporosis. So as you can see, number one cause of secondary osteoporosis worldwide is use of glucocorticoids. It causes osteoporosis because of multiple mechanisms. Firstly, it causes calcium excretion in the kidney, disrupting the calcium balance by causing higher bone resorption, and it increases it causes secondary hyperparathyroidism. It affects the osteoclastic activity, affects the osteoblastic activity. It can cause hypogonadism, low growth hormone, so gonadal hormones can go down. So multiple pathways can get impacted by glucocorticoid administration, causing osteoporosis. How do you stratify these patients? Can you use BMD versus FRAX? So BMD, once again, at the beginning of therapy, is a poor marker because it's good for follow-up scans to see how rapidly the bone is being lost, but not right at the beginning. So at the beginning of therapy, FRAX is better, and there is an adjustment that can be done. Steroids are provided for in your FRAX assessment questionnaire, but if the dose is high, because the dose is not taken into account in the FRAX, it's recommended that if the pred dose is more than 1 gram in total or 7.5 milligram per day, dosing is given, then you do this adjustment to the FRAX result. For the major osteoporosis risk, you multiply that by 1.15, and the hip fracture risk, you multiply that by a correction factor of 1.2 to get the result. So you have factoring in the higher dose exposure in the patient. And then, of course, as I said, a basic basal BMD with a follow-up BMD and a FRAX every 2 to 3 years will tell us whether we need to intervene and whether we need to treat even younger patients. Treatment of GIOP has been covered in many guidelines. I don't want to spend a lot of time, I don't have that much of time, but just to summarize that in older people, we would treat high risk and moderate risk people. So these individuals will be those who already have a fracture and who have what we would classify as osteoporosis, minus 2.5. Or would classify as major risk for fracture with a FRAX and would treat anyway. A fracture risk of more than 20% major and more than 3% anyway. In less than 40 years of age, the data for bisphosphonate or anti-resorptive therapy is not very clear and not very clear cut. So in those, if the fracture is already existing, they'll probably benefit. If the T-score is lower than -3, they'll probably benefit. But if you are keeping on doing a BMD and they are losing their bone at a rapid rate, more than 10% per annum, then probably they are going to get benefited by therapy. In older people, if the FRAX is intermediate, 10 to 19%, or HIP 1 to 3%, you may consider treatment also because they are older individuals and they have intermediate category of risk of fracture, they might. So the treatment options include bisphosphonates. You can see a summary here, oral as well as IV zoledronate works. DMAB works as well. Fracture data is not available for zoledronate and denosumab, but most of these therapies do work for GIOP. And prevention is for the older adults who are receiving higher dose of prednisolone. My final topic, in the interest of time, is to talk about diabetes and bone disease. It's a big topic on its own. I can talk for half an hour on that topic alone, but I'm just going to summarize for 1 minute. So type 1 diabetes, there is increased fracture risk, and they usually have a low BMD. In type 2, it's a bit funny because they also have higher fracture risk, but they have higher BMD usually, but poor microarchitecture and higher fragility. The two Gs, the glitazones and the glyphosines, the SGLT2 inhibitors, are associated with higher fracture risk among the therapies that we use as anti-hyperglycemic therapies. So here is a summary cartoon that summarizes the various influences of diabetes on the bone. So here you can see glycation end products causing weakening of the collagen fibers. You can see lack of insulin causing low IGF, resulting in weakening of the osteoblastic activity. Here you can see the PPA gamma influence, the influence of the adipokines, the inflammatory pathway, and a whole host of pathway that can result in bone being weak in these patients. Interestingly, you can see that AMPK pathway, the pathway in which metformin works, is right at the center of this bone metabolism. And interestingly, metformin probably has beneficial effects on fracture risk. In type 1 diabetes, meta-analysis shows that if the control is poor, or if they have higher duration of diabetes, or if they have neuropathy, then their fracture risk is high. So these are the people who have to be screened for and advised for about bone health. Periodontitis is also a good marker of bone health because they, as you can see in this cartoon, periodontitis and bone health are almost hand in hand, and looking at the mouth is a good way of looking at their bone health overall. So in the interest of time, I'm going to just summarize there, and I want to thank the ESI, Dr. Saptarshi, Dr. Sanjay Kalra for having invited me to speak here, and it's been an honor to be here, and I'm sure you enjoyed this talk as much as I enjoyed preparing and delivering it to you. Thank you.
Thank you, Noel. That was wonderful. Overarching view of the very sort of complex and broad subject of secondary osteoporosis, which covers so many things. So as we wait for the questions, I will just make a couple of maybe I'll ask a couple of questions. So what is the youngest age at which you would start a bisphosphonate in someone who's on steroids? Like kids get steroids for nephrotic syndrome, for example.
Yeah.
9-year-olds, 10-year-olds. When would you consider actually treating them?
Yeah, so as I said, the data for the under 40 is very controversial. So there isn't much data. Their fracture risk probably is a problem, and the reason whether you would give bisphosphonate in them is another question. In osteogenesis imperfecta, we do use there. In other patients, we are a bit cautious about. So unless there is an overarching reason, maybe multiple fractures, etc., I usually wouldn't start. I would try to support them with vitamin D, calcium, general bone health advice, etc., rather than starting on a steroid. So under 40, I think most of the guidelines try to steer us away from straight away barging on with bisphosphonates.